I think it'd be great to chat a little bit about methadone with everybody today. Some of these slides were adapted from Dr. Ketchum, who's also part of the bridge as well. I don't have any disclosures today. So our main objectives this afternoon are to examine the pharmacology of methadone, really to understand methadone's mechanism of action, its metabolism, and its effects. And then evaluate the evidence supporting methadone in OUD treatment, reviewing clinical research and outcomes supporting its efficacy and safety. Then outlining the regulatory framework for opioid treatment programs, summarizing key rules and regulations governing methadone use in opioid treatment programs. And then kind of focusing a little bit of this on primary care providers, but of course to anybody else, kind of addressing common questions and concerns I've often heard in my role as medical director here about methadone, and making sure that we kind of explore those frequently asked questions from primary care providers about managing patients on methadone. Just to kind of give a quick overview of those things. We're going to do that by doing this roadmap here of talking about each of those different topics. So we'll start with the pharmacology piece. I think everybody's well aware of this, but this is the most up-to-date data from New Mexico Health. And I think the pertinent piece here is that New Mexico ranks number 6 in overdose death rates in the United States. The primary driver for this, of course, has been synthetic opioids, particularly fentanyl has led that charge. Preaching to the choir here, but MOUD or medications for opioid use disorder are really the gold standard for therapy for opiate use disorder. And I think we're all familiar with these 3 different forms of MOUD, buprenorphine and its different brand name and generic formulations, as well as naltrexone and Vivitrol. But there is another one on this list that we often don't talk too much about, and that's methadone. And this is a recent article from Politico. This was just a couple months back. Really been showing a spotlight on methadone, particularly in the setting of fentanyl, because of its efficacy in treating opiate use disorder. Some even calling it a miracle molecule, while others are worried about how it could potentially even worsen addiction. And I think there's been some changes to the landscape of methadone. So I think it's really important for everyone, including primary care providers, to really understand a little bit more about methadone and understand those changes, how it could potentially affect your practice as well too. So a little bit about methadone. So it has a very, very long history. So initially started the use back in the around 1940s. It received FDA approval late 1947 for treating pain and coughing, actually. And then later on in the 70s, kind of early 70s, it was approved for supervised withdrawal or detoxification, as well as maintenance therapy. All this to say that it's been around for over 50 years now as a treatment for opioid use disorder, and it can be utilized to help many patients. So a little bit more about the pharmacology of methadone. It is metabolized in the liver and by the intestinal cytochrome CYP3A4. Most methadone is ultimately excreted in the biliary tract, but small fractions enter the urine and are detectable in urine toxicology screening tests. The oral bioavailability when swallowed is about 36 to 100%, but usually you're looking at about 80 to 95% when it comes to that. It is pretty lipophilic, so it has a large volume of distribution as well. So again, looking at all 3 different forms of MOUD, I think many of you are familiar with buprenorphine and naltrexone, but just for review here, methadone is a full agonist, right? So just activates all the opioid receptors, mu opioid receptors in the brain, whereas buprenorphine is a partial agonist and antagonist is naltrexone or Vivitrol. So that's what's unique about methadone as compared to the other 3 forms, is that it's a full agonist at the mu receptor. It is also very long acting, can last 15 to 47 hours with an average about 25 hours for the duration of therapy. That's why you see patients typically dosing every day when it comes to these medications. Compared to other forms of mood, specifically like buprenorphine and naltrexone, it has a weaker affinity at the mu receptor. And that's important when it comes to treatment, because if someone's on methadone and you were to give them buprenorphine or naloxone or naltrexone, those can precipitate withdrawal in the setting of somebody actively using methadone or maintenance therapy. It also has some other effects beyond the scope of this discussion. Has activity on other receptors, including the NMDA receptors and kappa receptors as well. And because it's a full agonist, it's really important to think about its effects on the patient's, overall health. A significant respiratory suppression can happen with the full agonist. So making sure, you worry concerns about respiratory depression, cardiac issues, those kinds of things, as well as QTC prolongation is a dose-dependent medication. So important to think about when dosing this medication. A couple of things about it. The dosing when it comes to methadone, especially at a methadone clinic or opioid treatment program, is pretty specific. Usually how this works is that the dose is gradually adjusted to reach whatever that therapeutic dose is for the patient. Traditionally, if you look at the old literature when it comes to methadone dosing, you're talking about reaching a therapeutic dose around 80 to 120 milligrams a day. But that dose can vary widely depending on the patient's tolerance and kind of overall health and symptomatology. You can see patients, I have patients at my clinic as low as a couple of milligrams. I think we have patients greater than 250 milligrams at my clinic as well too. So it's a wide window when it comes to what the therapeutic dose would be for the patient. But most patients are under 200 milligrams. I will say that this kind of is a historic number, and it has been changing a little bit more with fentanyl, especially with the high tolerance from fentanyl usage. We have been seeing patients that may sometimes require higher doses than what has been previously thought of as a stable dose. And that's a big deal when it comes to these dosing. So, methadone is really effective when patients dose consistently and maintain at a steady state. So they have to take the dose pretty much every day to make sure that they get into a therapeutic range here. Like I mentioned before, the dose is gradually titrated up to hit that therapeutic dose for that patient. Usually when it comes to starting somebody on methadone, traditional approaches have been about 30 milligrams, 20 to 30, maybe sometimes 40 milligrams of methadone. Historically speaking, that of course has been changing. There's been some recent literature out there, some recent kind of, studies that have shown that starting patients on higher doses, especially in the era of fentanyl, may be more beneficial, particularly when it comes to retention. So you may be seeing patients get started on, for example, at my clinic, we start somebody on 40 milligrams of methadone and then go up by 20 milligrams a day to get them to 80 milligrams in a few days. But usually you would see most clinics operating under about no more than 10 milligrams a day when it comes to methadone dosing. And that's because you want to make sure it's safe for the patients. Usually patients prior to the fentanyl era, it would be a little bit more concerning to go up very quickly on their dose. But since that's all kind of changed with the way we're approaching things nowadays, it may be safe to go up a little bit more rapidly, a rapid titration. When do you know someone's at a therapeutic dose, or when they feel like things are better for them? Usually they won't be having any cravings. So, that feeling of wanting to use, but also no withdrawal as well too. Those are really the target points we come to when it comes to titrating someone's dose. But you also want to balance that with the, sedation properties of a full agonist that we mentioned earlier. So also making sure that the patient isn't sedated and able to achieve, normal sleep-wake cycles and able to function throughout the day appropriately. Balancing that with the cravings and withdrawal piece is really critical when it comes to finding a stable methadone dose. If you do this a little too slowly, though, like if you titrate at a low dose over an extended period of time, patients feel like the dose is typically ineffective and they typically drop out, which only encourages continued opioid use. So it's kind of an art to when it comes to finding the therapeutic dose for somebody on methadone. So what is the evidence for methadone? Really, there's a couple of landmark studies. I think hopefully you're all familiar with this, but compared to patients receiving MOUD, untreated patients with opioid use disorder at 1 year have a 2.5 time all-cause mortality risk and 8 times overdose mortality risk. So there's a lot of mortality literature when it comes to methadone and MOUD in general. And that also was in a couple of other studies that have come out. But basically the big things for these is that patients out of treatment died at about 6 times the rate of people in the general population, while people on MOUD with methadone specifically brought this down to less than 2 times. So very helpful for a mortality benefit. And also the other thing to think about too is retention. So retention in methadone and buprenorphine treatment is associated with substantial reductions in the risk for all-cause and overdose mortality in people with opiate use disorder. So a lot of benefits in the literature about this. I think just a take-home point that I often tell folks is when you look at the literature or the numbers needed to treat specifically, for like antihypertensive medications to reduce a bad outcome, specifically with mortality, you're looking at a number needed to treat for antihypertensive drugs at about 125. But when you actually look at the numbers needed to treat for somebody on methadone, it's about 40. So it's a lot, you get a lot more bang for your buck for giving somebody methadone, even with an antihypertensive medication. So it does have a huge efficacy profile there when it comes to mortality. I wanted to highlight a couple of recent publications that have come out. I think this is important to discuss. This one came out about a year ago in Lancet Psychiatry. This was a systematic review and meta-analysis of buprenorphine versus methadone for the treatment of opioid use disorder. This is often a question a lot of people ask is, what should my patient be on when it comes to these things? And really, there's a couple of highlights from this study. I think the first one was, and this has been proven in other studies as well too, but there tends to be a higher retention with methadone as compared to buprenorphine. So, and that rate has been shown over multiple variables of time, from as little as 1 month all the way up to 12 months. You see a higher retention rate with patients on methadone as compared to buprenorphine. And that may be suggestive of more effectiveness for long-term treatment adherence for patients on methadone as compared to buprenorphine. There's a lot of thoughts as to why that may be. It may be components of methadone system that we're going to go over here in a minute, including counseling components, regulatory things, as well as toxicology requirements, those things. That's an idea, or it could be just from the medication itself. It really hasn't been teased out, but it has shown to improve retention as compared to buprenorphine. The other thing that's important when it comes to both these medications is that they have a similar adherence rate. There's a little bit better buprenorphine adherence for patients with like extra medical conditions with opioid use disorder as compared to methadone in this meta-analysis, but it kind of varied by the study method. So overall, pretty similar when it comes to adherence. And the other thing that was found in the study too was that there were some unique benefits between the two, just to think about. So buprenorphine was associated with reduced cravings and anxiety as compared to methadone. But when you look at patients who are on methadone, they had fewer hospitalizations overall and lower alcohol use. So important to kind of think about some of those things when it comes to, picking the right medication for somebody. This was another study that just came out. It literally was published last month. This was in JAMA, and it was comparing, again, buprenorphine, naloxone or Suboxone to methadone for the treatment of opiate use disorder. And again, the big highlight here was higher retention with methadone. In this study specifically, methadone showed a significantly lower rate of discontinuation as compared to buprenorphine over two years, actually. So an even wider thing than what was done before in the review of literature that we just discussed. They had comparable mortality rates. And really, I think the big thing that this thing was bringing up as far as JAMA went was that there needs to be some policy changes for methadone. It can be an effective first-line treatment for opioid use disorder, but there are so many regulatory issues with it that there was a call for action when it comes to that. Which brings up the next highlight, the next segue here. What are those rules and regulations when it comes to methadone? And I think by far, this is one of the most regulated pieces of medical treatment I've ever been involved with. There are multiple agencies involved when it comes to methadone, specifically federal, state, other pieces too. So federal, there's SAMHSA, the DEA. State, there's the Healthcare Authority and the Board of Pharmacy. There's accreditation bodies that are unique to the methadone world. But really, all of this boils down to what's known as 42 CFR, or what's Title 42, Part 8 of the Code of Federal Regulations. This is really the rule of the law when it comes to how a methadone treatment, opioid treatment program specifically operates. And what that means historically is that you have to get methadone for the treatment of opioid use disorder through an opioid treatment program, or OTP, which is also known as a methadone clinic. Inductions, as compared to buprenorphine, have to be done face-to-face. So you can't do this over the phone. You can't do this via telehealth under those past kind of regulations that we just spoke about. There is a 1 hour at minimum counseling requirement that must be done for patients. There is at least one toxicology sample that must be obtained per patient. And the concept of what's known as take homes, or actually getting medications to be used at home instead of coming every day, are pretty restrictive. In order to qualify for these medications, For example, to get one additional day of medication per those kind of rules, you would have to follow a treatment protocol and follow all these things for at least 3 months just to get an additional day of medication. To get up to 13 days of medication, it would take sometimes up to 15 months. So highly regulated, can be very difficult and challenging for somebody to get to the clinic. These are the rules and regulations for those take homes. This is an actual flyer at the clinic that I work at now, just to show you how much somebody actually has to do. Absence of recent substance use, regulation of clinic attendance, absence of serious behavioral problems, absence of criminal activity, stable home relationships and, stable home and relationships. They have to have a certain time and treatment that we talked about before. They have to assure that the medication can be stored safely and that the risks of getting this outweigh the benefit when it comes to getting these take homes. So a lot of things that patients had to go through. And because of that, patients typically just get dosed daily at the clinic. Most patients, for the most part, at least in my clinic. This is what a dosing window looks like. Patients come to the actual opioid treatment program, and there's a window or a line where patients get the medication poured directly to them, and they consume the medication in front of the staff there, particularly a nurse who's observing this whole process go down. And because of that, there can sometimes be a long line when it comes to patients waiting to get their medication. This has to happen pretty much sometimes every day for the patients if they're not following all those criteria. So very challenging to do. This is a picture of some of those take homes that patients are fortunate enough to get. I do want to say there is some hope, and there's been some recent changes. So just last month, there was a federal change to 42 CFR, which is called the final rule. And the good news is it really changed the take-home requirement. It is allowed for flexibility up to 28 days of that medication in accordance to kind of some changes that happened during COVID-19. It allows for telehealth admissions, which again increases accessibility, and allows APPs or advanced practice practitioners to actually prescribe methadone in an OTP setting still, but without a supervision of a medical provider, MD or DO. So there's been some changes when it comes to this, which I think are hopefully going to increase access and decrease the burden of having to come to the clinic every day. I just want to briefly touch on this, which is the Modernizing Opioid Treatment Access, or MOTA Act, which is in the Senate currently. This is a highly kind of debated topic, but different organizations have different thoughts on this. There are some that are in favor and some that are against. So what is this specifically? Basically, it would allow methadone prescribing from outside of an opioid treatment program. So basically, a provider could prescribe methadone at a Walgreens, for example, and the patient could go pick it up and get it there instead of having to come to an opioid treatment program. As you can imagine, the American Association for the Treatment of Opioid Dependence, which is the Association of Opioid Treatment Programs, or OTPs, is not in favor of this, whereas many of the addiction medicine medical societies are greatly in favor of this, including ASAM and AMERSA. And I think recently another huge medical organization also signed up for support of this. So this could change the way that anybody prescribes methadone. So I think it's really relevant to keep on the pulse of what's happening here when it comes to things, because you may be in the future be able to prescribe methadone from your own clinic, which I think is pretty a dynamic change to the way things are actually happening. All right, so the meat of this, what are some common questions that primary care providers have? And especially if you're going to be prescribing things, what are some questions I've heard of that I think people should be familiar with? The first question I get often asked is, does methadone actually show up on the prescription drug monitoring program? And the answer is it does not. So that 42 CFR kind of prohibits the disclosure of sensitive materials, including someone's methadone prescription history. And only RXs filled in pharmacies are reported to the state PDMP. So because it's coming from an opioid treatment program, it does not have to be placed on that PDMP. So how does somebody actually figure out if what their dose is and how that works? Well, you have to get permission from the patient actually in order to do this. But in emergency situations, you can contact the clinic directly if you know where the patient's going and ask them to verify their dose. It's a pretty simple process, calling the clinic, telling the patient's name, date of birth, those kinds of things, and getting the dose from the clinic. But yeah, it can be a challenge to determine if somebody is actually on this medication. I've met multiple patients that have not told their primary care providers for fear of retaliation, for fear of concerns of, they may not prescribe me an agonist or something if they know I'm on methadone, or I may be treated in a different way because I'm on this. So I encourage you to have those, to build those relationships with your patients and try to find out if they're on it, but technically they don't have to disclose that to you. The other big question I have is what medications interact with methadone? There is a long list of medications. I think relative to a primary care provider, a lot of the mental health psychiatric medications that we talk about can have a direct effect on the metabolism. We mentioned the CYP3A cytochrome being involved with this. You can have inducers or other things that happen with these medications. So it's really important to know this. For example, even other antibiotics that you prescribe, like Cipro, for example, is an inhibitor of methadone, and it increases the serum methadone levels if you give somebody that. So there is a long list. I'm happy to share those resources. But again, many of the common psychiatric medications can really go through that. Should I be worried about the QTC? Yes, methadone can prolong the QTC interval. It is actually a dose-dependent relationship. So lower doses, less risk of QTC prolongation, higher doses, greater risk of QTC prolongation. And the concern, of course, with QTC prolongation is torsades that can happen. You get higher risk with those increased doses, and also people with a history of familial prolonged QTC syndrome. So important to ask that about for patients with a methadone history. But of course, any QTC prolonging medications, right? Those are things that can also, in addition to the methadone, even increase that QTC even longer. So important to realize those medications that are QT prolonging should be kind of watched and monitored if you're giving those. Also, other electrolyte abnormalities, of course, just like anything else, can contribute to that QTC prolongation. So hypokalemia, hypomagnesemia, those kinds of things will happen. Typically, it's recommended to consider getting an EKG, although I think most providers think to do that, but you actually don't have to get an EKG when it comes to starting somebody on methadone at a clinic, just as a heads up. Can you prescribe methadone for pain management? So this is another question that comes up pretty quickly. Oftentimes, somebody getting discharged for a hospital or something, do they have to go to an opioid treatment program? Can I just write them a prescription for methadone? Hopefully this discussion kind of answered that. No, for the treatment of opiate use disorder, you have to get methadone through a methadone clinic or opioid treatment program. You can prescribe methadone for pain management, and sometimes colleagues like in palliative care medicine or chronic pain do this. I will say, though, that those are doses that are significantly lower than what's typically used in a opioid treatment program. There can be an increased risk of diversion for these medications, though the way the onset for analgesia is a little different than when it comes to actual, OUD treatment. So it's really, I would defer not to do that if I was in a primary care practice, but really you can, but not for the purpose of OUD treatment. I think this is the big question that I often get more often than not is, should my patient be on methadone or buprenorphine? When would you choose this? And like, what's your kind of algorithm when it comes to starting these two medications? For me, I think, MOUD, it's what fits the patient best, right? And usually patients will tell me what has worked or hasn't worked. If someone's a de novo patient, though, and has never been on any of these things, I think given what we just mentioned with all these rules and regulations that go on with methadone, although there are some changes, it is still a lot easier for somebody to get buprenorphine than it is methadone. So if it was a brand new patient, at least to me, I would probably consider that primarily first before considering methadone. However, I do look at the whole picture when it comes to tailoring, the actual choice of MOUD in the patient. And you kind of have to look at all these things. I think if somebody can make it to the clinic with regular attendance and doesn't have any transportation issues, those kinds of things can be big barriers to getting to the clinic. You have to make sure that that bridge is crossed first. But I also look at other things. So if somebody, for example, has a history of chronic pain, that may be a good thing. If someone has a history of QTC prolongation, respiratory depression, things where full agonism may not benefit them, on the other hand, I would probably defer to buprenorphine for those patients. So, I mean, it really is a discussion to have with the patient to figure out which one is the best for them, knowing what we just mentioned here, that it may be a regulatory burden to get to the clinic. But most often I try to tend towards buprenorphine first when it comes to my own practice before going to methadone. That being said, though, like I mentioned, methadone has a lot of treatment benefits. And if someone's been on buprenorphine before, and it was difficult for them to adhere, or it just didn't work out for them, certainly consider methadone. It does have a strong efficacy. It does help with retention. So I think, you kind of have to kind of look at the whole picture here when it comes to picking for the patient. Another question that comes up quite often is, can somebody get switched from methadone to buprenorphine? And the answer is yes, but I will say it's extremely challenging in an outpatient setting. I have done this successfully and non-successfully before in the past. Really, what I would recommend is, if you're trying to do this, really reach out to the patient's opioid treatment program and coordinate with the medical director there. They're usually great folks, and they want to help patients, even if that means transitioning them to buprenorphine. They want to help make sure this works. Just so to familiarize you with how this works, there are two different approaches. One is the traditional approach, and this is the one that's been used historically. Really, what you try to do is taper somebody's dose down to around 30 to 40 milligrams of methadone on the OTP side. And then you want to hold that dose for a few days and then start a buprenorphine induction. I can tell you, though, from experience, that somebody on a really, really high dose, like 150, 200, going down can be really challenging. They will experience withdrawal. And then that period of time of remaining abstinent for 3 days at minimum, the longer, the better. But that window there is a very scary area for somebody who's just recently gone down, probably having withdrawal symptomatology and is not receiving treatment. Can be a scary time for somebody before initiating buprenorphine. So it can be really hard, and I would encourage you to, meet with or talk to an opioid treatment provider before doing that. There is this other option, which is the low dose induction option. That is sometimes a better option for folks, but it does require co-prescribing of both methadone and buprenorphine at the same time. And sometimes, again, that can be a challenge. It can be done here at the OTP because I'm kind of regulating that. I haven't had too much success with other like private practice providers with this, but it is an option. The great thing about this is it doesn't necessarily require the methadone dose to be adjusted or lowered or stopped until the buprenorphine dose is therapeutic. So basically, you're just slowly increasing the amount of buprenorphine in someone's system by cutting things in halves and quarters, et cetera, small doses, and escalating that dose up, just like a typical low dose initiation, except albeit with methadone. It can be challenging also from a patient perspective, though. Cutting these doses, quarters, films, et cetera, can also be a challenge. So again, all this coordination of care is really important when it comes to these things. So in summary, just for time's sake, I think the key points here are: methadone does not show up on the PDNP. Please call a methadone clinic to verify a dose. Methadone metabolism can be affected by many medications, especially psychiatric medications. So make sure you review those medications prior to prescribing or discussing them. Methadone can prolong the QTC, so be mindful when prescribing QTC prolonging medications. It cannot be prescribed for OUD outside of an OTP. There are disadvantages and advantages of using methadone as compared to other forms of MOUD. Please tailor your choice, of course, in collaboration with your patient when it comes to what's the best option for them. And then transitioning between these two things can be a real challenge. Make sure you coordinate with the opioid treatment provider. And I would also suggest consider consulting the New Mexico Poison Center, talking to one of the specialists on call to kind of help navigate that kind of treacherous thing. And again, it's highly effective as compared to buprenorphine, has high retention rates. It's highly regulated, but I think recent changes are coming in that may loosen those regulatory burden up a little bit. That was a quick whirlwind through all of the methadone stuff. I'm sure there's more questions about that, but that's at least a primer on it. Thank you for your time.